I'm Dr. Asim Javed. I'm an interventional cardiologist working at Rawalpindi Institute of Cardiology in Pakistan. This is a series of talks to facilitate learning process for performing mechanical thrombectomies in acute ischemic stroke.
So, four facts about stroke and TAVR. The first fact, stroke is an issue with both TAVR and surgical aortic valve replacement. It is true that with low risk patients, the risk might be a little low, and with high risk patients, the risk is a little higher. But the fact remains that irrespective of the risk, the stroke rate is there. Now, the second fact is that although with increasing volume, we've become better, and that has resulted in better outcomes in terms of mortality, vascular complications, and bleeding. But the stroke rate did not change. If you look at this one comparing the low volume centers with high volume centers, again you can see that even with high volume, the stroke rate did not differ. And the fourth fact is that about 50% of strokes are procedural. So that means it's not 100% procedure related stroke with TAVR, but still 50% is good enough that if we pay meticulous attention to procedural details, then we might be able to reduce the stroke rate. Now, majority of these strokes after TAVR are ischemic, and most of them occur within the first 24 to 48 hours of TAVR. What's the mechanism of this embolic stroke? It could be because of balloon dilatation in a severely calcified valve, passage of devices at aortic arch, catheter debris, carotid disease, thrombi, and if you look at the material that has been captured, that includes debris, thrombus, valve tissue, collagen tissue, calcium, endothelial tissue, myocardial tissue, so all sorts of debris that goes to the brain. Now, there are disabling strokes, but at the same time, there are clinically silent brain hits, which at that time do not present clinically with stroke. So, new cerebral lesions are identified by MRI in TAVI patients in almost 70 to 90% of cases. And although termed clinically silent, the presence of these lesions has been correlated with development of progressive cognitive dysfunction. And this is associated with 2 to 4-fold risk of future stroke, more than 3-fold risk of mortality, more than 2-fold risk of dementia, and cognitive decline. You can also see here that the rate of silent brain infarcts in TAVR compared to all other cardiac procedures is slightly higher. So, what can be done about it? Can we prevent this? Cerebral embolic protection devices are now available. You can see different varieties, different shapes. How effective are they? So the one that's most studied is Sentinel filters. They got the FDA approval in 2017. So what you do is you go 6 French transradial, and then one of the filter is deployed in the brachiocephalic artery, the other one is deployed in the left common carotid artery. So 90% of the blood brain is protected, but 10% here is not protected. Left vertebral artery is not protected. So that's a downside. The good thing about Sentinel, it doesn't have much material hanging in the arch. So the device is coming from here in the arch. There is least interaction with Sentinel filter. And this one size accommodates most vessels. Now, as I said, this is the most studied cerebral embolic protection device for TAVR. Now, this is Sentinel IDE study, and what it showed was that Sentinel captured debris in 99% of patients. So it's very effective that way, that in 99% patients, it was able to capture debris. It is safe with no increased 30-day MACE, but the reduction in new cerebral lesion volume was not statistically significant. So it did not make much of a difference here. So why Sentinel got its FDA approval is not because of stroke reduction, but primarily for its effectiveness in catching debris. This is why it got its FDA approval as cerebral embolic protection device. Since then, there have been many single center registry studies comparing the incidence of stroke with and without cerebral embolic protection, vast majority of them, although have showed some degree of stroke reduction with sentinel devices, but then came this protected TAVR trial, which is a big trial with 1500 patients in the TAVR only arm and 1500 in the TAVR with cerebral embolic protection. Um, and what you see here is all stroke, not much of a difference, and disabling stroke, there is a trend towards lesser disabling strokes with cerebral embolic protection. So if I conclude the protected TAVR trial, it was a negative trial, and cerebral embolic protection with the Sentinel device did not reduce the periprocedural stroke, but Sentinel use was associated with fewer disabling strokes. Now, do we know who is a vulnerable patient? Well, if we break down the risk factors like age, gender, operative risk, valve morphology, valve calcification, what we actually find out is that it appears that everybody undergoing TAVR is at a risk for stroke between 2.5 to 4%, irrespective of gender, age, or any of these factors. So all patients undergoing TAVR are vulnerable to stroke. Now, there are so many embolic protection devices that are coming into the market. Many of them are under trial. This is probably the largest study undergoing right now, British Heart Failure Protect TAVI trial, and it's going to enroll TAVI with cerebral embolic protection, 3,865 patients, and the same number without cerebral embolic protection. This trial might be able to give us some answers. So now, what to do with periprocedural disabling stroke? We've talked about the risk factors, we've talked about the material that goes up, we've talked about how to protect it, but what if you can't protect it and the patient does have a disabling stroke? How will you manage the stroke then? So, based on the histopathological data, IV fibrinolysis with alteplase may be detrimental or ineffective. Why detrimental? Because there's been a recent arterial access, 14 French or more, and there's a risk of hemorrhagic conversion of about 6 to 9% in the ischemic stroke. And ineffective could be ineffective. Why? Because in 50% of embolized cases, the debris was not thromboembolic but tissue related, myocardial tissue, endothelial tissue. So there the fibrinolytic will not be effective. So mechanical thrombectomy with or without intra-arterial fibrinolysis intuitively makes more sense. Now, just to give you an example, this was our 10th TAVI case done at Rawalpindi Institute of Cardiology, a 65-year-old gentleman with history of diabetes mellitus, hypertension, advanced COPD, and double vessel coronary artery disease. In 2021, underwent PCI to LAD. He was a surgical turndown at that time due to severe obstructive pulmonary disease. Now he presented with 2 episodes of syncope and dyspnea on exertion and NYHA class 3. Echocardiogram showed calcific severe aortic stenosis with MPG of 51 millimeters of mercury, Vmax 5.6 meters per second, concentric LVH, no aortic regurgitation, and ejection fraction of 50%. Blood profile was normal, frailty scale was 3, life expectancy more than 1 year. Now that's the coronary angiogram done in September 2023, which shows patent LAD stent, and mid to distal LAD disease was decided to be kept on medical treatment. So no intervention required before TAVR. So looking at the CT scan, there were some concerning factors like there's a calcific valve, there's calcification on the outer curvature of the aortic arch, and then there's concentric LVH with no aortic regurgitation. And the valve size decided was 29 millimeters. So we went through the right common femoral access under local anesthesia with ultrasound guidance. Predilatation was done with 18 by 40 millimeter wax 2 balloon. Wax 2 was the one on our shelf at that time. So the balloon slipped and we had to give a second inflation to get the valve open. Confida wire was used for pacing. We placed the valve, but it was a little deep placement while positioning the valve, and therefore we had to recapture the valve. The moment we recaptured the valve, the patient went into cardiac arrest, asystole, and CPR was initiated. And during CPR, immediately 29 millimeter Evolut R valve was deployed with ongoing CPR. And after a little while, there was a return of spontaneous circulation achieved with adequate positioning of TAVI valve. There was minimal paravalvular leak, well perfused coronaries. Two proglides were used to achieve access site hemostasis. We did a quick bedside echo in the cath room, and there was no pericardial effusion. TPM lead was passed, and the patient was placed on mechanical ventilation. Now, on ventilator, patient developed atrial fibrillation, for which we had to give IV amiodarone. Patient was extubated after a few hours. He was vitally stable, normal vital signs, and chest cardiovascular sounds were normal. GCS was 15/15, but the patient had a power of 1/5 in the right lower limb with upgoing plantar. So the patient probably had a stroke. Why would he have a stroke? What could be the possible etiologies in this particular case? We did the predilatation twice. So that's one risk factor. There's a calcific aortic arch. We might have caused a stroke while crossing that aortic arch. And the third one is the patient also had atrial fibrillation. That's another cause. So in any case, we did a stroke code. Immediately took the patient for CT brain, which did not show any intracerebral bleed, and the aspect score was 10. CT angiogram was done, and CT angiogram did not show any large vessel occlusion, so no LVO. The next step, CT perfusion was done. And if you look at the CT perfusion, you will see yellow color coming up in the left anterior cerebral artery territory. There you see that. So left ACA had perfusion defect there, although we could not pick anything on the CT angiogram, but CT perfusion definitely showed defect in the left ACA. So it was few hours that the procedure had finished. So we were concerned about the groin access, but we had done proglides very effectively and we were confident about it. So we gave the patient IV TPA, that's thrombolytic therapy. And post TPA CT brain did not reveal any bleed. Patient was discharged on day 5 with power 3/5 in the right lower limb. And when he came back for follow-up after 4 weeks, his power was 5/5 in all 4 limbs. So he had fully recovered from the stroke. Now coming to a second case, Pakistan Live 2023, the case was being done in Lahore. Live TAVI case, patient is on ventilator, case went very well. A case finished, patient was extubated, and immediately after extubation they realized that the patient had stroke. So he had aphasia and hemiplegia with 0/5 power in both right upper and lower limbs. We did a CT angiogram which showed an occluded MCA M2 territory. We took the patient to the cath table, and this is the DSA image showing where the artery is blocked, and then that's a micro catheter which actually we took in with a wire. Wire has been removed, and this is the tip injection from the micro catheter to confirm that we are in the true lumen in the vessel. And then we decided to go ahead with the Sulumbra technique, which is a combination of aspiration and stent retriever. So Solitaire X 4/40 millimeter stent retriever was deployed in M1, M2 region, and 6 French Sophia plus aspiration catheter was taken along with it. So both were then removed together with suction on aspiration catheter, and the stent retriever also pulled back, and complete recanalization took place with Tiki 3 flow. The interesting part and the miraculous part was that the patient regained 5/5 power on the cath table. So it's important for cardiac centers performing TAVI to have in-house arrangements for stroke intervention. Cardiologists should be able to manage their own complications even if they don't want to run a stroke service. Thank you.